good evening. Hello. Okay. Wait, did I fix the... Okay, I fixed it so that I wouldn't be delayed. I don't know if the chat is real time now because every time I stream on YouTube, laging late yung chat. Laging late yung chat sa akin. Well, late yung stream, I guess. But it looks like this time it's not late. Okay. Filipino time even on YouTube. Yeah, hello. Oh, Rian, hello. Wait, Rian. I will make you. How do I? Ay, paano ba to? Oh shit! I have to do it on YouTube. Okay, wait lang, Rian, ha. Where is it? Oh, ito. Ito. There we go. There we go. Okay, I think you should have the wrench now, Rian. I gave Rian a wrench. So, you should have it now. Yeah, it looks like it's not delayed anymore. Alright. Anyway, good evening, everybody. Hello. You just click on the... Yeah, I did. It's just, I used OBS and the thing wasn't popping out. The options. So I had to go to YouTube. Mismo. Okay. So... Alright, if you guys are on my Discord or on my Twitter or on Facebook, I made an announcement the other day, Sunday, that I will be holding a mini donathon. Excuse me. I'll be holding a mini donathon on this coming Sunday for a patient. Because recently I have this patient who came to me and he needs surgery. Okay, he needs a surgery. But he also expressed having a hard time with the funds for the surgery. This surgery is not simple. I mean, it could have been, but it's not. And so I decided to help him out. Of course, I didn't tell him that I was a VTuber. I didn't tell him I was a VTuber. I said, sige, tignan ko kung anong pwede kong gawin. Hanap tayo ng makakatulong sa iyo. That's what I was like. So, yeah, this stream here on YouTube is just an introduction to what the case is. Of course, I'm gonna keep him anonymous for, patient confidentiality, but I will tell you when it comes to the disease at hand. I will tell you guys what his disease is, and some what we found in his imaging, ultrasound, CT scan, blah blah blah, and what the surgery will be, and we'll talk about that. So I'll probably even have some YouTube videos help me with that. you know, so I can show you how the surgery's done. So expect some gore, basically. Expect some gory videos. Okay. Shall we name the patient done? Alright. Oh, wait. You know what? I forgot. I think I should... Wait, I'm gonna take my keyboard off. We're gonna use a tablet because... Oh. I'm gonna use a tablet. What's this keyboard? I'm gonna put my keyboard in this. I'm gonna have a tablet. Because I wanna be able to write on my slides, so wait, tablet here. Shall we name him donothon? Actually, you know what? If there are patients that come to the hospital or to the ER that have no identity, or you can't identify him, we call those patients John Doe. That's their name. Their name is John Doe. And if it's a male, if it's a female, it's Jane Doe. That's what we call them. So it's not Don Juan. Alright, wait, hold on. Where's the... Oh no, where's the glove for my tablet? Actually, oh, there it is. Mama still had kidney issues when she was alive, so I tried to read about it. Kidney is actually complicated. Especially medically speaking. Okay, hold on, let me just wear the gloves. Am I wearing this right? Okay. Oh, wait, I haven't turned on the tablet, have I? Mapping. There we go. Alright. Okay, so yeah. Like I said, this stream is just gonna double as a... Tawag dito? As a medical education stream, but it's also an introduction to the case of this patient, okay? I'm gonna use pen. Oh. Okay, I'm just choosing a pen color, I think. Haha, blue. Okay. Blue. How do I erase this? Alright, there we go. Alright, let's go. Let's get started, okay? Yeah, this is a case presentation. This is gonna be similar to how I do case presentations in the, you know, hospital setting. You know, sometimes when you're a doctor and then you have to present cases, sometimes you gotta do it on a PowerPoint. Anyway, so this is a big case presentation. I just dumbed it down a little for laymen, because I'm sure there are medical terms that you guys might not understand, but so I tried dumbing it down a little, but there are some terms that I had to retain, okay? Alright, let's go! Oh, why is it not working? Wait, why is this screen not... Ah! My keyboard's not working! Bruh. Okay, resist. Okay! So the patient data. We have an old person, okay? We have an old person who is male, and he lives somewhere in Manila. Normally in patient data, when we do this, you write the initials of the patient. Like, let's look at the chat. Leon Steele would be like LS, for example. Let's call the patient LS. And then he's a male. Sometimes we put the age also, so the age would be here. Let's say LS. I don't know. Let's say he's this is gonna be an old person, so let's say he's 69. 69-year-old male. Okay. Lives somewhere in Manila. Let's say lives somewhere in Manila. Let's say, I know, lives in MOA. Sa mall nakatira. He lives in MOA. Okay. Hindi, sa mall siya nakatira. Okay. That's usually. Sometimes we also put like religion like that. Let's say go for the usual religion of the the most common religion of the Philippines would be Roman Catholic. Let's assume that, okay? Nakatago sa mawag. Yeah, basically. Okay. Then next slide. Alright. History of the patient's illness. Okay, of the present's illness. So, our chief complaint is an anterior neck mass, okay? Basically, it means there is a bulge on his neck. Sometimes we put a separate slide for the chief complaint, okay? So the patient came in complaining of an anterior neck mass. So 1 year prior to consulting, he noticed a bulge on his neck that slowly grew. So in medical terms, we would be like, patient noted a gradually enlarging mass on his neck. He occasionally had difficulty swallowing. Difficulty swallowing, we would call this in medical terms dysphagia. We call this dysphagia in medical terms. Yeah. Alright. But that's basically it. So his symptoms persisted and he consulted. Okay? Consulted the doctor. So this is a very short history of the present illness. Usually if you're a medical intern, or if you're a junior intern or a senior intern, they make this really, really long. So or a med student, there we go, med student. Are there any med students here? I'm pretty sure if you're a med student and you're doing clinicals, they teach you how to do the history in a very, very detailed way. So if I had a med student do this, get the history of the patient, it's gonna be like 3 paragraphs. It's gonna be like 3 paragraphs, and then as you go higher in the hierarchy in the medical field, you're gonna like cut down your 3 paragraphs into like 3 sentences, and you're good. All right. The dreaded HVI. Yeah, I remember when I was a medical student, I would write like essays of histories. It would take like how many paragraphs? But then when you become like a resident and then a consultant, when you become like an intern, it gets a little shorter, probably like 1 paragraph. And then when you become a resident, it's just like 5 sentences. And then when you become a consultant, it's just like 1 to 2 sentences. Something like that. Because then you know, as the older you get or the longer you are in the practice, you already know what's important, so you just focus on that. Shortcut soap in post-grad. Yeah, exactly that. Alright. Review of systems, unremarkable. Usually here in review of systems, they put a list, but I just made a shortcut of it, unremarkable. They just put here the other signs and symptoms that the patient had that may or may not be related to his current condition. So like, let's say, or his main complaint is an abdominal, is a mass, anterior neck mass, right? So sometimes they say, I also lost weight. I also sometimes get abdominal pains. Something like that. You would add it here. But then he didn't have any. Okay. So, next. Past medical history. So this patient is a known case of hypertension, and if I remember correctly, he's taking losartan, and I think he's also taking amlodipine. He's also taking amlodipine tablets. I forget the dosage. He says he has no diabetes. DM is diabetes. No previous surgeries. Okay, denies all that. He denies also having asthma, denies everything else. Yeah. Okay. Let's see. Next. Family history. He claims nothing. He says that his family doesn't have any hypertension, no diabetes. His family, no one in his family has a history of goiter or a neck mass or cancer. So all of that is just nothing. Okay. Di pa tuli. You don't really add that to the past medical history unless it's very, very important. Let's, like, for example, the patient says, penile swelling, and then, like, you know, he just had a circumcision recently. Alright, next. Oh. Personal social history. Okay, he denies being a smoker. So this is where you put, like, smoking, yung mga bisya niya, the vices. So he denies smoking. He denies drinking alcohol, though I really think he's lying about this. Denies illicit drug use. So yeah. He probably occasionally drinks. I don't know. I never believe. You know, when a patient says, I don't drink alcohol, I don't believe them, actually. I have a feeling they, like, drink really occasionally. But yeah. Dr. House says everyone lies. Yeah. He probably drinks, like, occasionally. Occasionally. I don't know, but he says he doesn't. Hey, I had a patient who denied taking drugs. And then but then his what you call this? His illness wasn't making any sense at all. His condition was not making any sense at all. So I asked him again, "Are you sure you don't take any?" He's like, "No, I don't." And then I start talking to his, like, a wife or something. And then she admitted to him taking meth. I'm like, aha! You liar! Liar! Alright. Next. Alright, physical examination. This is very, I just shortened it, okay? So this is very targeted. Usually a physical oh my god, there's thunder! Oh my god, thunder! I don't know if you guys heard that, but there's thunder. Usually, what am I saying? Usually, if a med student was doing this, it would be like a really long list, complete from head to toe, physical examination. Like, wow. It would be longer than this, but I shortened it. So this guy, patient has a palpable neck mass. So on the left of his anterior neck, we have a 4x3 cm, approximately, mass. Oh, I forgot to describe it. It's like a spongy in consistency or texture or whatever, or what. Palpable neck mass, right? Approximately 5x3 cm, also spongy. Okay. Yeah, it's kind of soft. It's not too hard. It's just spongy. And then mass moves with deglutition. Deglutition is a medical term for swallowing. So when he swallows, it moves. So when you swallow, it moves upward. Okay. No palpable cervical lymph nodes. So in Tagalog, walang kulani na nakakapa. When you auscultate his chest, he has clear breath sounds, and when you listen to the heart sounds are distinct. The heart rate is regular. The regular has a regular rate. The rhythm is regular, and there are no murmurs. Usually, murmurs are signs of, like, congenital heart disease or having a hole in your heart. Okay. Yeah, warm pain. No pain. It's non-tender. It's, wait. Okay, let me, no warmth. It's also negative for tenderness. Okay. It's spongy. Oh, if it's movable, non-movable. Only it moves when you swallow. Okay. Thyroid, excuse me, a thyroid gland is 2 lobes, okay? The thyroid gland looks something like this. So this is like, this is my drawing of a thyroid gland, okay? That's why you have left and right. So this would be the right and this would be the left. So the right one is larger. Oh yeah, the right one is larger. Let's see, larger than the left. The left is also large, but not as much. Okay. Alright. Next. Primary impression, or my diagnosis. So without any laboratories. Oh, is his speech clear? Yes, his speech is clear actually. He speaks well. It's clear, it's not rough, no hoarseness. There we go, no hoarseness. Primary impression is an anterior neck mass to consider multinodular non-toxic goiter. Because this is always... when someone comes in with a neck mass, you think, oh my, there's goiter. You'd think goiter. But then you can also... my differential diagnosis would be... differential diagnosis. Let's say, thyroid neck mass, right? I would think of thyroid, so thyroid malignancy or thyroid cancer. Malignancy. But given all that, we're just thinking of goiter. Thyroid problem. That is so general. Okay, let me just take a sip of mine. Okay. Alright, next. Okay, ultrasound. This is a little messy, but I'll go through it one by one. I have the details. I did not what do you call this? I did not write down, put here in the slides the exact details. I just took the readings here. These are all the the conclusions or the impressions of the imaging. So the patient first had a thyroid ultrasound, which showed a thyromegaly with multiple nodules. Thyromegaly just means big thyroid. Like larger than normal. Thunder is really booming, yeah, I know it is. But if I were to, let's see, do I have a... Hold on, let me check my... If I could read out the measurement, hold on. So you guys know exactly how large it is. Hold on, okay? So yeah. Where is that? Do I have it here? Oh wait, it's not. Wait, hold on. Okay, hold on, guys. I might. Wait. I am going to. Wait lang, guys. Where is it? Oh, here it is. I have it. I have it somewhere here. So, this one. No. about it. Wait. Okay, hold on. There we go. Okay, I got it. Oh. Okay. I got it, okay. Alright, the thyroid, okay. So the thyroid, the right lobe is around 5.4 cm by 2.3 by 4.2 centimeters, okay? So that's like, let's see, the largest, where is it? Largest would be 5.4 cm on the right lobe. And it has a mass. It has a mass. It has a mass that is measuring 4.5 cm. There we go. And then he has also like little tiny smaller masses measuring like 1.1 cm, 0.4 cm. So he has like multiple nodules. And then on the left, he has, the left measures like 4.3 cm. And then you have like a mass that measures like 1.5 cm. And another one measuring 2.3. But he just has multiple nodules, like what it says. So a CT scan was CT scan was done also, because it was a really big, and they just wanted to know how big exactly. Like, does it go down into the chest? And they did a CT scan. Okay, they did a CT scan of the neck, and wait, here we go. So, in the CT scan, the thyroid's even larger. Okay, the right thyroid lobe was like really big, and it was measuring up to 10.5 cm. So that is huge. Okay, that is big. The left lobe is just like 5.9. So it's actually larger than what the ultrasound said. Alright, and okay, so intrathoracic extension. This means, what that means is that the thyroid is reaching into the chest. So you know you have your neck here. This is your shoulder. So you have your thyroid here, which is big. It's going down like this. You have another thyroid. That going down there. Okay, something like that. This is your chest. Okay. So that is big. So this is the right lobe, and this is the left. So it's something like that. It's reaching down into the chest. Okay. Cervical lymphadenopathy bilateral. Okay, so where exactly are the lymph nodes? The lymph nodes are... Hold on, let me double check. Okay, it says here, level 3. So if you know your neck anatomy, you'll be able to find where that is. Oh, this is on the left. This is the left. And then there's also in level 5. 5B on the right. So it's bilateral. Bilateral meaning both sides, left and right. Okay. And on chest x-ray, they also saw the thyroid on the chest x-ray, which is moving the trachea. Okay, it was moving the trachea to the left. So how do I draw this? Let's draw a neck right here. Shoulders. I don't know if you can see. Alright, so because the thyroid is so big and shit, like really gigantic. It's big. This is your trachea, where you breathe. It's like moving to the side. Because of this, it's pushing it aside. Okay, usually the trachea is like goes straight down, Okay. Alright. Next. I'll show you photos later. I have some photos so you guys can see. I will tell you about the levels of the neck for those who don't know what that is. I will show you guys later. Oh, and because the CT scan of the neck showed that the thyroid was going down into the chest, we had to do a chest CT scan also. And in the chest CT scan, where is it? In the chest CT scan, the thyroid's even larger, okay? Right thyroid gland. If a while ago in the neck CT it was 10, this time it was a whopping 12.2 cm. Okay, this is probably because it was able to see the thyroid gland more. In the neck CT scan, it only captures the neck, right? So it only captures, that much. Chest CT scan includes the whole chest, so you can actually see the extent of the thyroid mass. And then it says here the trachea was shifted to the left, so like I showed you guys, with intrathoracic extension. So yeah, the thyroid gland is going into the freaking, into the chest. So let's draw that one more time. Clavicles. Okay. Alright, so if we're gonna draw the thyroid, it'll probably be something like this, like big and reaching down like this, and then you have the thyroid. Like that. Something like that. And then it has nodules, right? It says here it has multiple nodules. Wait, hold on. Yeah, the other image says it has multiple nodules, so like probably like that. Yeah, looks something like this. So this is the thyroid. Okay. And then his trachea is like, let's draw the trachea. Moving to the left like that. And you have to draw something like that. Okay? Alright, so that's what we have. Oh, Walt, hello! Just got here. What tests were shown? I just showed a CT scan. So, this is his thyroid. Basically, it looks something like this, based on the CT scan. Okay. Alright, next. We did a biopsy, okay? Fine needle aspiration biopsy. So what is a fine needle aspiration biopsy? And the result was papillary thyroid carcinoma. So fine needle aspiration biopsy is when you use a syringe. Use a syringe. I'm trying to draw a syringe with a needle. Oh my god, this is ugly. Thyroid. Let's try the thyroid. Yeah. You're gonna get samples of the thyroid and then send it for biopsy. Okay. And it came out as cancer. Alright. Great syringe. It's actually a small syringe. I took biopsies of both, so like I got from the big one, and I also got from the small one. Okay, so I had to take both. This is guided with ultrasound. I used an ultrasound also because I have to get the right nodules, you know. Alright. So yeah. Now, why is this interesting? Okay. What is the surgical plan? Now, usually for thyroid, Doc, nasa YouTube ka. When it's medical education, I do YouTube, okay? But if it's like regular gaming, then I do Twitch. Twitch is still my main platform. So what is the surgical plan? The surgical plan. All right. Usually, let's draw this. Yeah, usually for a thyroid, if it was just goiter or a simple cancer, you just do a total thyroidectomy, where you just have the incision is right here, and then you just take out the thyroid. But there's some things here. One, this patient has an enlarged thyroid gland, enlarged thyroid with multiple nodules. There we go. He has bilateral. Let's see, bilateral cervical lymphadenopathy. Oops, lymphadenopathy, meaning he has lymph nodes seen, and then he also has intrathoracic mistake. How do you erase him? Wait, erase him. Oh. Okay, intrathoracic extension. Okay, there we go. Because of these are the three things. Enlarged thyroid, multiple nodules, you just do a total thyroidectomy. But then since we have these, it gets a little more complicated than that. Okay? And I'll tell you guys, I'll show you why. Okay. For the first procedure, total thyroidectomy, we'll remove the thyroid gland. Alright, that's the first thing we're gonna do. So this is an image of the thyroid. Like I said, this is the thyroid, but in his case, in our patient's case, his thyroid is very big. So we have this. It probably goes like this. Probably even lower. Yeah. Then this one. Oh. This one. There we go. Something like that. This is his thyroid. His thyroid gland is pretty much like that. And then this is his trachea, the white thing here. That's his trachea, and it's just moving. It's moving to the side, to the left. So it's probably like that. Okay. So that is a big ass thyroid. And sometimes there are thyroids that do extend into the chest or into the thorax, but they are removable through a normal through a usual total thyroidectomy. But this one is actually a lot larger than usual. You know, some thyroids could probably extend to like wait, hold on. Let me get another color here. Let's use red. Alright, so some thyroids could like extend to like, let's say, like here, like that. But those are easy to get through an incision on the neck. Okay. So that is an understatement, more like your gaunt one. Yeah, it's actually really big. What's the complications on removing the thyroid? Oh, okay. You can if you remove the thyroid, you're gonna be like forever on meds to increase your thyroid hormone, because you would produce like the thyroid stimulating hormones, but then you don't have a thyroid to stimulate, so you don't produce the thyroid hormones. Doc, since there's an intrathoracic extension, will there be a collab between the neck surgery? Yes, actually, that's actually why. That's why. Hold on. Before we, I'll get to that. So total thyroidectomies I've done. I just realized the thyroidectomy is not shown here. It is supposed to be thyroidectomy. Okay. I've done a lot of thyroidectomies, like no problem. But one thing I've only done once ever, cause you know, is this. Alright. If the lymph nodes that were shown in the CT scan were, I think what were invaded were, level 3 and level 5, if I remember correctly. These were the lymph nodes that had enlarged, so that would be here. Wait, let's get a blue. Let me get my blue ink. Yeah. So that would be the lymph nodes were, I think this one was on the, I can't remember, was this the right or the left? But anyway, we're looking at the left side of the neck, but anyway, the involved lymph nodes are here under this muscle. This muscle is the SCM, or the sternocleidomastoid muscle. So, SCM is the sternocleidomastoid muscle. You can actually feel that, you know, the muscle on the sides of your neck. You can actually feel that it's this chunky muscle on the side of your neck. This is the muscle that helps you turn your neck left and right. Okay. So the lymph nodes are underneath that, and then we have the posterior lymph nodes in level 5. So these were the involved lymph nodes. Okay, 3 and 5. At least that's what we're seeing in the CT scan. So the next procedure, aside from a total thyroidectomy, is a bilateral. Bilateral meaning both sides, because we have both sides involved. Modified radical neck dissection. This is a surgery that I have not done in very long. So yeah, this is what makes it complicated. So what is a modified radical neck dissection? So in shortcut, this is on MRND. Call this an MRND, guys. This is where you open up the neck, so you know how in total thyroidectomy your neck incision is just in front. This time the neck incision goes up higher on the side of the neck, and then what you're gonna do is remove the lymph nodes. But usually when you remove the lymph nodes in an MRND, you remove levels 1 to 5. So that includes lymph nodes here, lymph nodes here, so lymph node 3, 4, and 5. And then there are types. There's MRND type 1, type 2, type 3, and this... Oh, are there any med students here? If there are any med students or residents or interns, this is a very common question in exams, by the way. And I'm gonna tell you, okay? So you guys don't forget. They always ask this in every exam, like even when you're from med student to like intern to resident. They always ask this, never fails. Never fails, they always ask this question. What are the different types of MRND? They will ask you, so I will tell you. So, in a modified radical neck dissection, aside from removing the lymph nodes, there are also other structures you remove, okay? So, one of them, another one, so we have the SCM, right? The sternocleidomastoid muscle. There's also the IJV, or the internal jugular vein, okay? So, internal jugular vein, okay? And lastly, you have a nerve. The spinal accessory nerve, okay? Spinal accessory nerve. So these three are what are gonna be affected here. Well, more like two of these three. So when you say MRND or a modified radical neck dissection, you remove these lymph nodes and one or two of these three here. So how do you remember what it is? If they say MRND1, that means you're gonna spare one of these structures. If you say MRND2, you're gonna spare two. And if you say MRND3, you spare all. So an MRND3, let's start with 3 first, okay? An MRND3 is removing the lymph nodes and not touching any of this. So you save all for 3. Save all. Okay? You spare the sternocleidomastoid muscle. You spare the internal jugular vein, and you spare the nerve, the spinal accessory nerve. Okay? And then for MRND2, you're going to spare 2 structures. So all you gotta do is just remember that among all of these, the most important one is the nerve. So you don't touch this. You gotta spare the nerve. So what is removed here is just the SCM and the IJV. So you spare SCM and IJV. There you go. Okay? And then here you're gonna spare one, which is the nerve. You spare the nerve. So basically, if you do an MRND1, you're gonna lose this muscle right here. If you're gonna do an MRND1, you're going to lose this muscle, the sternocleidomastoid muscle. I don't know who you are, but you got a pretty voice. Thank you. I'm a ShioriPon. I'm a surgeon VTuber. I'm a rogue surgeon VTuber, but I'm also a surgeon in real life. So I'm doing a medical education stream. But this is also about one of my patients. One of my actual patients who is gonna have a big surgery coming up. And he just needs help with funds. So I'm just introducing everyone to this case. And I'll be holding a donathon for him on Sunday. But it'll be held on Twitch. Okay? Alright, I hope you guys got that. For the med student, if there are any med students or anyone who needs to who get confused with this, because I also get confused with this. MRND. They will always ask this. Whether it's in your exam in school, whether it's your licensure exam, whether it's in your exams as a resident, or even your board exam. Yeah, they're gonna ask that. Okay, they always ask it. Alright, let's see. Next, here we go. These are the different incisions of a bilateral modified of a modified radical neck dissection. So, preferred incisions would be this. I'm gonna guess that we're gonna go with something like this. Because we'll probably do this one. Like a letter Y. Something like that. Maybe. I think this is what the best one will be for him if we're gonna do bilateral, because it would be really weird to have this one is really hard to do. This is way too high. This thyroid is over here. Thyroid would be here. So yeah. So it would be like a letter Y. So if this is his neck, you have the thyroid incision, and then you're gonna go up like that. So his incision is actually getting larger now. Alright. Next. And then the third part of the surgery is a median sternotomy, which will be done by a thoracic surgeon. So yes, this patient was referred to TCVS. TCVS, or a thoracic thoracocardiovascular surgeon. So the chest surgeon or the thoracic surgeon. And they're going to open the sternum. The sternum is this, the bone on your chest, in the center of your chest. The hard bone that you feel in the center of your chest is called the sternum. And yeah, so if this is a very big ass thyroid, which you see right here, originally the incision is gonna be like this for the thyroid, but then we're also gonna do a bilateral neck dissection, so it'll go like that, I guess, something like this, like the letter Y. And then we're gonna have to open up his chest so he has another incision go extending downwards like this. So his incision's gonna be a letter Y. Imagine the scar of this, guys. Okay, that's how the scar on his neck is gonna be. A bone saw, yes, a bone saw is needed. Definitely, we're gonna have to cut the bone. Now, I'm not a thoracic surgeon, so, but I vaguely remember how it was when I rotated in TCVS when I was like a junior resident. But yeah, this is not my specialty. But I will be assisting the thoracic surgeon because we gotta get this thyroid out. Or what, more like the thoracic surgeon is gonna be assisting me. Could you get a raspy voice? Ah, yes, there is a big risk for that because in thyroidectomies, there is a nerve here. Well, I'm gonna draw the trachea, okay? Or this is a trachea. Let's say this is the trachea, which is this one right here. Let's take like this. This is the freaking cartilage. Yeah. Anyway, there's a trachea, and then your thyroid would be like that, right? Let's draw thyroid. There is a nerve that passes down here like this. There's a nerve here called the recurrent laryngeal nerve. The recurrent laryngeal nerve. If you accidentally injure one, if you injure one, you'll get hoarseness. So, or that raspy voice you're talking about. Hoarseness. If you injure both, the patient will have difficulty breathing. DOB. Difficulty breathing. So, it's very, we have to try as much as possible to avoid injuring the nerve. Because you don't want to have this patient be raspy, be like paos forever, or have a hoarseness forever. Lab test before operation is probably yes, FT3, FT4, TSH. For this patient, it's actually normal. So this patient is euthyroid. So he doesn't have hyperthyroidism or hypothyroidism. Okay. Yeah, it's a big thyroid, but you know, since it's cancer, we gotta and there's multiple nodules, you gotta remove everything. So there's that. Oh, yeah. Hold on. So, oh, all right. And how would it look like in an actual patient? Here, oh my god, it's so small, but I should have made it larger. But this is not an actual patient. I just pulled this out of Google. But this is basically how the patient is going to look, probably in the surgery, in the operating room. The patient has been marked, so you can see like there we go. This is the mandible, and then this is the where the level 2 lymph nodes are, and then level 3. And then level 5, level 4. Okay. This is your SCM. Okay. that would be how it will look like. And I think that's my last slide. So, hold on. Let's go look for... Oh, I see why my keyboard isn't working. Hold on, I'm gonna replug my keyboard. We're done with the slides, I guess. Okay. I'm going to... Okay, let me turn that off for a while. And we're going to go... I'm gonna put aside my tablet now. Wait, hold on. I'm gonna put my tablet aside now. Oh. Because we're done using it. Next pop quiz. Not yet. Not yet. Let me just plug in my keyboard. There we go. Alright, let's see if we can find MRND. Oh. Oh, what? My keyboard is not... MRND. I'm gonna look for a video on MRND. Whoa, this is a 2 minute long. Alright, here I found one. Here, let's do this. We're gonna go to... There we go. Okay. I'm gonna turn off the BGM. There we go. Alright, there we go. Okay. This is, I have no idea. I think this will show... Will this show? Here we go. Oh. Ooh, look at your muscles. There we go. We got lymph nodes. Yeah, the sternocleidomastoid. Oh, this is for neck masses that are not thyroid, though. Because if it's thyroid, you gotta remove it out. There we go. Modified radical neck dissection. Hey, this one is pretty good. It actually shows you. I like how this actually uses like AI, I don't know, text, yeah, AI. I was gonna say AI voice, text to speech. So yeah, hold on. I think there's an. Oh hey, this one has like FAQs and this has FAQ. Oh, with techniques. Because I think I've only done this like once It is, I'll see that. I think that will be the incision we're gonna do. So yeah, it's gonna be like this. Wait, do they have like a one with thyroid? Oh, there, they actually explain also the wait. I think there we go. The internal jugular vein. Wow. I think I'm gonna have a hard time finding the nerve when I do this surgery. Man, I'm actually preparing really, really hard for this because I haven't I have to like talk to my bosses, and I'm probably gonna ask for help also for this because yeah, this surgery is a lot more complicated than it is. Like, this is going to be actually, you know how many people would ask me, what is the hardest surgery you've done or the most complicated surgery you've done? For me, it's gonna be this one now. Because usually, the reason why I for neck surgeries is a little challenging is because as a general surgeon, we are there is a specialist for this called the ENT or the HENT. They are the ones who usually do surgeries on the neck, the face, or ears and all that, the throat. So they usually get all the thyroids. But then as a general surgeon, you're supposed to know how to do these surgeries too. So sometimes as general surgeons we also get cases like these, but not as common as the ENT. So yeah. I remember in case in my old job where the doctor needed to monitor ionized calcium before and after. Oh, because of the parathyroid glands. They're like little glands hidden underneath the thyroid. You gotta make sure you don't remove those. So yeah. But diba Doc, dangerous yung nasa neck because of the main artery? The carotid artery. Yeah. You have to definitely have to avoid the carotid artery. But usually it's very easy to identify the carotid artery because you can actually feel the pulsations. Carotid artery pulsates really, really strongly, so you won't miss it actually. So yeah. Do you leave a bit of thyroid tissue where the parathyroid are embedded? No, if it's a total thyroidectomy, you remove the entire thyroid. You gotta remove it, especially if it's cancer. You gotta remove it. Wait, I think... When is when is radioactive iodine treatment acceptable for management of cases like these? Oh, we usually do right after the surgery. After, but before the surgery, I don't think, especially for a case like this, you do it after. Yung thyroid, yan ba yung sinasabi nila na lumiliit kapag, ano to? Yung thyroid ba yan ba yung sinasabi nila na lumiliit kapag na-expose ka sa radiation? What do you mean? Wait, it depends on what you mean by radiation. If you mean like radiation, like out there, you're just standing there where there's radiation. Your thyroid is like one of the most affected. That increases your risk of getting like thyroid cancer. But if you're like radiation therapy, that's a different thing. Or radioactive iodine treatment, that's a different thing. For killing them cancer cells. Oh, okay. You know what? I have an idea here. Wait. Let me close this. Alright, let's, for those who are... Yeah. This is American Thyroid. Here we go. There is like a... I'm gonna open up some guidelines for you guys. The secrets to the thyroid. Hold on, let me open it. Oh no. No, not this one. I have to pay to access this. What the hell? I have to pay to access this. Holy shit. Okay, wait. Asan na yun? Oh. Here we go. 2021. Ito. Okay, let's get scientific. Is this? Aha! Okay. Oops. Alright. There we go. Let's get scientific, guys. Wait, hold on. Okay. So, this is the updated guidelines. American Thyroid Association guidelines for the management of... Oh wait, this is anaplastic thyroid. Wait, I got the wrong one. Hold on. By the way, anaplastic thyroid is like the worst thyroid cancer you can get. It is the worst one. American Thyroid. It is the worst. It is a very aggressive cancer. The anaplastic one. Teka lang ah. Ito ba yun? But the patient I have has papillary, so it's not as bad. I mean, not as aggressive as the other one. Oh, what the heck? Oh no, I need like... Seriously? Wait. Hold on. Ito. I had that though, but you had what? You had what? Wait, I'm trying to get the latest guidelines because these are too old. In a level from 1 to... Oh fuck, how bad is thyroid plastic? Anaplastic. It's anaplastic thyroid carcinoma. Anaplastic. That is the most aggressive one. Like, if you have that, it's like... It's bad. It's oh fuck bad. Because most of the time they don't have long. It grows really, really fast. It grows really, really fast, the anaplastic thyroid cancer. And I can't find those guidelines anymore. What the hell? I saw them and now they're gone. Popularity. Okay. American Thyroid Association. Papillary. Ours is papillary. Papillary thyroid cancer. Here we go. This one. You see, the thing with anaplastic thyroid carcinoma is, if that is diagnosed, most likely the cancer is gonna grow really big in like the span of a few months, and it has a tendency to like invade into the trachea or compress the trachea that you have difficulty of breathing, and then most of the time, or a lot of the time, these patients need the tracheostomy. They need to have a tube inserted into their trachea, so just so they can breathe. That's how crazy it is. Oh, I can't find. Oh. I can't find it. What the heck? I found it like days ago, but I can't find it now. I have to pay. It's behind a fucking paywall. This sucks, man. That's it. You know what? I'm gonna use my secret unlock. Secret unlock. We're gonna unlock this. We're gonna unlock this without going through the paywall. We're gonna go through the paywall without paying. Oh man. Wait. Hey, wait, this is not the one. Nahanap ko, guys. Oh, by the way, guys, do you know... Oh, wait. Before that, I want to ask you guys, those who are in the sciences course, you know there is a website. I don't know if you guys know this, but I learned about this, like, a long time ago. There is a website where you can, like, access journals for free. You know how some journals or research papers are behind paywall? And you need to, like, pay just so you can read the entire thing or to get the entire PDF file. There is a website where you can actually, you just type in the DOI and then you have access to the freaking... You can get access to the freaking... the whole thing. Please do share. Wait, I'll show you. Wait, hold on. I'm trying to look for the actual, the guideline. There we go. Yeah, Kian got it. It's Sci-Hub. 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 Bro, that helped me so much. Sci-Hub. It, like, every research article I had to get or like access it they have it, man. They have it. Yeah, it's Sci-Hub. Let me show you. Sci-Hub. Teka lang ah. Sci-Hub dot ito ba yun? Aha! Okay guys, I'm gonna show you some cheats. Pinagbabawal na technique dito. Okay. Pinagbabawal na technique. I freaking hate the paywall. Yes. Yes, they gotta. Okay. I'm gonna show you guys. People who want to know how to. You see this? For example, this is the journal I want. Okay, this is the journal I want. So what I'm gonna do is I go to the journal. See, they only give you the abstract, right? And you want the whole journal, but then when you're like full text, they're like, you have to subscribe and all that shit. What you do is you look for the DOI. The DOI. Which is, here we go. DOI. Get this. You get this, copy it, and then, go to Sci-Hub. Sci-Hub! Sci-Hub, paste it on here and then open. And it should... Oh no, they don't have it! No, they don't have it! Sci-Hub has failed me! Sci-Hub has failed me, oh no! Ah, man. Okay, let's try the link. You can use a link. Let's try this. No! No, they beat Sci-Hub! Someone tell the person hosting Sci-Hub they need to unlock this journal! They did! Capitalism won this time. No! No! Sci-Hub, you failed me! Oh my god! Oh man. Okay. Alright, let's just go for the... You know what? You know what? I'm gonna go for the old one, just so you guys have an idea about the guidelines, okay? We'll go for the old one? Like, fuck this, let's go for the old one. Ay, ano ba to? Okay, we got a PDF file here. What's that again? Where the fuck? Where is the... Oh, this is a very long... Wait, hold on. There should be like a... Oh, here we go. This one's a good one. Okay. Alright! I got a PDF file here. This one is free because it's 2015. Yes, I was teaching you guys the Forbidden Jutsu, but then the paywall one. Paywall one, okay? There's an algorithm. Here we go. See this? There's an algorithm when it comes to thyroid masses. So, if you have a suspected thyroid nodule or a thyroid mass, you do like an ultrasound, and then they describe it like if there's a high suspicion or intermediate suspicion or whatever, then you do a biopsy. Okay, a biopsy, and then once you do the biopsy, if it's benign, you don't do anything. If it's non-diagnostic or unclear, you do a biopsy again. And then, if it's suspicious or malignant, you do a surgery. Okay. So, yeah, this is it. This is the journal. And this, we gotta know this. We have to know this because we have to know how the thyroid looks like in a freaking ultrasound. So, yeah. Where's the thing about... is there like a... Oh god, wait. There was a more, I found one that was like, showed a really good, just a shortcut algorithm, but this is a lot of reading. So, actually, thyroid is a very complicated, well, no, it's not as complicated as breast. Thyroid is complicated, but breast is worse. I hate breast. I hate breast a lot. I don't know any other ones aside from Sci-Hub, so if you guys know, if any of you guys know, you feel free to share to me. Because apparently Sci-Hub couldn't unlock the one I wanted to unlock. LiveHub, oh, okay. I love breast. Nah. Wala sa Schwartz. Oh, okay. Schwartz. Let's talk about Schwartz. Schwartz is a very, wait, you know what? Let me go to... Ito. Oh my god, wait, you guys are in the way. The chat's in the way. Okay, let's take chat away first. Okay. Let's see. Schwartz is Let's see. Schwartz is it's a textbook for med students. It's meant to be, well, it's also for like general knowledge on surgery, like especially for exam purposes. Yeah, you go Schwartz, but not everything is in Schwartz. Okay, so no, the one I'm looking for, it's not really in Schwartz. There's like different guidelines for thyroid that even I get confused about which one am I supposed to follow. There's like the American Thyroid Association guidelines. There's the NCCN guidelines. There's like the ESMO guidelines. There's so many guidelines. So yeah, there's hierarchy for medical literature, pretty much. But Schwartz is the Schwartz book is the they call it the Bible for surgery. That is the book for surgery, especially for like general knowledge. Journal article, textbook transits. Yes, especially if the journal article is reliable. But you have to start reading all that. Because, the reason why they go for, like, they would say journal articles is because medicine as a science is always changing. It's always evolving. You know how science is not an exact thing. It's not just whatever you discover, that's it. That's it. And that is the only truth out there. No. There's always something that's changing. They say, like, science is full of laws and theories, but they always change eventually. And it's the same with medicine, because medicine is is a science. So there's always something new. And this is why I hate breast. It is the reason why I hate breast. Because the breast is always changing. There's always new stuff popping out about the breast, and they keep changing the guidelines. They keep changing what you need to do for the breast. And I hate it. This is why I hate breast. I hate breast as a doctor. Like, there's so many things you have to know about breast. Like, I think, when was it? Like in, they had staging. Cancer staging for breast. Cancer staging for breast used to be like this for a long time. Until in like 2016, I think, or 2017, 2018. Suddenly they have this new way to stage breasts because they added all this other stuff. Like, oh, you need this to finally stage the breast cancer. I'm like, oh my god. What is this? And it's like so long. It's so long. I should show you guys. I will show you just how bad, just how freaking hell and satanic the staging for breast is. Where is it? Bruh. I'm looking for it. Hold on. But I just remember it was like multiple pages that I had to read. I'm like, oh my god, do we have to memorize all this shit here? It had multiple pages. Ito. I can't find it. Ito ba yun? Okay, it's not here. What? Don't tell me it's behind a freaking paywall again. It's always behind a paywall. Bayan. Oh man. Ano ba yun? Oh no, that's not it. Ito. Can't find it. Holy crap. Okay, I can't. I think it's behind a paywall. Yeah, I think it's behind paywall. I can't find it. Oh my god. Breast constantly evolving. Yeah, but that I really hate. I don't like breast. It's not as simple as removing the breast when you have breast cancer. There's a lot more to it. There's a lot more, and they found out a lot of other things. There's so many things you have to know. So yeah, I hate it. But anyway, I think we're good. So that is the patient I am going to be doing surgery on. He has no schedule yet for the surgery because we're still prepping him. And the reason why we don't have a schedule yet for him is because he's lacking funds. So yeah, for those who are here, I will be holding a donathon on Sunday, and it will be on Twitch. It will be on Twitch, the donathon. So let me write that down here. I haven't made the... I will be posting the... Oh, wait. Okay. I will be posting the details of the donathon later. I made the thumbnail, but I will show. I think I can show you guys while I'm still making up the incentives actually. But if you want to see the dono goals, I can show you guys. I will show you. Hold on. Did I save this? Okay. Ano ba to? Okay. Hold on, guys. Where is it? Oh. Why is it in a freaking... Oh, okay. Bakit naging ano? Wait lang, guys. Wait. Oh, what? Oh, okay. I see why. There we go. Alright. Let me show you all. Oh, shoot. How do you extract this? Oh, there we go. Okay. Why is it not? Why is it not? Oh, there we go. Donothon. Alright, here it is. I will show you. I think this... Oh, is it soon? Wait, where is it? It disappeared! Ito. Why is it not? Okay. There we go. Oh my god, my face. My face! Okay. This is the donathon goals. Sneak peek for the donathon goals. Okay, here we go. So yeah, this is it. So I will be holding this mini donathon on Sunday. It'll be on Twitch. Okay, it'll be on my Twitch channel. And her face is behind a paywall. A paywall. Here we go. Fine. This is the paywall behind my face. This is the donathon, the mini donathon. I'll be holding it on Twitch on Sunday. So the stream on Sunday will start at like 2 p.m. and it'll be 2 p.m. onwards until like 12 midnight. Okay. So yeah, all proceeds will be for the patient. Okay, 100% of everything I get from this donathon will be for the patient to help him with with his surgery, because he's really having a hard time and he needs the surgery. You saw how big his thyroid is. He needs it. He needs it. Okay. And yeah. if there's any extra from let's say we reach the stretch goal, okay? The stretch goal, the rest, all of the money, if there's any extra, they will go to, I will put them aside and they will still be for like future patients who need the money. Okay? So 100% of everything I earn, I get from this donathon will go to patients. They're not gonna go to me. It's not gonna be for me, it's for the patients. Okay? For at least for this donathon. Okay. So I will set up my gank for this. I will set up gank for the donathon, and the donations can happen in gank so that they will be in one place. Okay. Alright, so I'll post this later. I'm still fixing like the incentives. Alright, so yeah, that's all. That's all for tonight, guys. I hope you guys learned a lot. I hope you guys learned a lot about that. It's just really about my patient, and just wanted you guys to know what exactly the donathon is for, and at the same time I wanted to teach you guys about his case. It's actually a lot. It's complicated. It's a lot more complicated than I thought it would be. I mean, it's not an easy case. I thought it would just be a thyroidectomy, but no, I gotta go after the lymph nodes, and I have to refer him to a thoracic surgeon, and I have to, like, you have to open his chest. Yeah. I-pay walang quiz. I-pay walang quiz na. Okay, guys, I'll let you guys off this time. No, walang quiz. because this one is really, it's really about the patient, it's about my patient. So yeah. Okay, so no pop quiz. Yeah, walang quiz. Next time may quiz. Next time, mag-aral kayong lahat. Mag-aral kayo sa next. Thanks for the lesson. Hey, no problem. I hope you guys learned something from this. Malang quiz kasi na paywall. Okay. Otsupon, guys, and yeah, I'm glad that this time the chat is not delayed. My stream is not delayed for you guys, so the chat is. I don't have to wait like. I mean, you guys don't have to wait like how many seconds before I actually answer your question. Chat is more real time now. Alright, so Otsupon, everybody! My next stream will be on, ano ba next stream ko? Nakalimutan ko na. What is my schedule? As usual, I don't remember my own stream schedule. Hold on. Aha! My next stream is on Thursday. Yeah. I'll be streaming on Twitch, okay? So for those who just found me now here on YouTube, I mainly stream on Twitch. Twitch is my main platform. I use YouTube mostly for video uploads, highlight videos, clips, and medical education streams. And speaking of video uploads, I'll be uploading my alternate outfit debut VOD here. Maybe later tonight I'll upload that. So if you guys want to watch my alternate outfit debut, you guys can watch it. I streamed it on Twitch. So yes, you can follow me on Twitch. I stream mostly gaming content there, but I also do like chatting. That's my main platform. It's fun. It's fun. You can actually, if you're new to Twitch or you don't know Twitch, you can throw things at me on Twitch. You can get circumcised on Twitch. You can you can get circumcised. You can throw things at me. You can head pat me. You can you can play with me. With karaoke, yeah, it has karaoke. Oh wait, it has karaoke, right? I think YouTube is pretty strict when it comes to karaoke, I think. Oh, shoot. It's strict with karaoke. I might have to chop out the karaoke part of the debut. Or maybe or you know what? Maybe I'll have someone make a highlight video of it. So, yeah. Bawal daw support. Alright guys, Otsupon, thank you for coming to my stream. I hope you guys learned a lot, and yes, please support me, support my donathon. I hope we can reach the goal of $500. It's just $500. And if you know, bahala na if we can get the stretch goal, but the important one is the $500 for him. It's all for the patient so that he gets better. I hope he gets better. Okay? Yep. Lots of fun. Good night, everybody. Bye-bye. Bye-bye.